actually get this conversation rolling and doing it in 5 minutes. But it's doable. And last, but not least, one of the major barriers that I've encountered within the literature is that as physicians, we're just really bad at having these conversations. Because either we're uncomfortable with it or we don't feel trained to have these discussions, and palliative care might not be readily available. So there are many ways to have that conversation. This is a template you can use. First being the status quo, just addressing what's going on. And when you talk about, and then you talk about the prognosis, and then ask about what's important to the patient and the family. Finally, get to that point, get to the point of the plan of care. Wording and how you phrase things when you discuss with patients and family is very important. I just want to point out these few that I found that I thought was interesting. The first, do you want us to do everything possible? We kind of heard about that that's not the best way because it's very broad and patients and families kind of confuse what does everything mean. Of course they want to do everything. If it means having their loved ones more for longer periods of time, why wouldn't you want the physician to do everything? But instead, just focusing what's important to your loved one. What do they value? The same thing for the second. Would you want him or her, would you want the patient's name, want heroic measures? The families and patients don't know what that means. Address what they were like before the illness so that not only you build patient-physician rapport, but kind of know what they value and how they were like and how this would fit into their end-of-life care. I've definitely been guilty of using the third one and describing CPR or the DNR, DNI. Do you want us to push on patient's chest, use electricity, and provide the patient with a breathing tube? Although it might work on a subset of people, having this graphic description of the DNR, DNI, or the resuscitation process, it's not very effective. If, like I said, if this means bringing their loved ones back, why wouldn't you want to do everything? Why wouldn't you want, because we have the technology. Instead, focus it on dying a natural death. And I think that's more palatable to patients and their families. Instead of, because we know exactly what happens, but they might not see it our way. So if you focus on dying a natural death, I think families and patients will understand better and have a better peace of mind. I found this one interesting. I wouldn't want this for my mother or father or loved one. I've heard this a couple of times, and people have, said this. While it's not wrong, patients might not want to hear what you want because right now they're in distress. This might be one of the worst days of their lives. Seeing their wife, husband, mother, father in a critical condition. You don't want to focus the attention on you. You want to focus on them. So tell me about your mother. And then there's nothing more we can do. While we understand what that means in terms of medical futility, it's not always true. You want to flip it and say that we will aggressively do everything we can to make your loved one comfortable. And I think that has a more positive outlook, positive connotation to it. So like we discussed before, after we talk about the status quo, the patient and family will want to know about the prognosis. How much time do they have left, right? Physicians as a whole are very bad with giving bad news. And it's understandable. We're all human. We want to cling to hope. We want to say they have more time than they actually do. But that doesn't really help in real life. And prognosis in itself is difficult. There's some data for cancers of how long you have, depending on what treatment or the natural course. But how do you prognosticate a 67-year-old man who has end-stage renal disease, COPD, end-stage heart failure with an AICD, who's coming into the ED for his third time for dyspnea just this month alone? There's no prognostic tool for that. and for that specific scenario. But you can use, there's a lot of data on the palliative performance scale and using performance as a prognosticator of prognosis. So this is just an example of the palliative performance scale, and it did be something based on activity, evidence of disease, self-care, fuel intake, and level of consciousness. And the PPS is graphed against survival rate. Just note that this is for terminally ill patients, so it's not you and I who has a 70% score on PPS right now. That's not for normally ill people. This is for patients with terminally ill, life-threatening terminally ill diseases. And you can see, at best, those that have a score of 70%, only 7% survive in a year. So going back to this case, the questions I asked you were from a survey that was sent out to emergency physicians. And for the most part, the results were kind of what we had here. 96% of people believe that the patient will die during hospitalization. 94% believe that intubation will not provide any benefit. Interestingly enough, despite having a DNR/DNI order, 26% would still intubate the patient if the family insisted. And I think if we started recognizing and implementing palliative care early on, we would have that number go down. Atul Gawande wrote A Poignant Peace in 2010, it's a while ago, but he wrote about his experiences in palliative care. And in it he mentions La Crosse, Wisconsin. Does anybody know what's interesting about La Crosse? So it spends less healthcare dollars at the end of life than any other place in the country. And the reason and how that all started was because they all started talking. So there was one physician who saw this problem and had his nurses, whenever any patient came in, his nurses, his staff members, and the physicians asked the patient, at this point in time in your life, if you had an incurable disease and you came to the ER, what would you want at the end of your life? That got the conversation starting, and patients talking to the emergency physicians, the primary care physicians, that most people, I would say 90% of the people there have advanced care directives. And if they didn't, they were the odd ones out. So in summary, identify patients who can benefit from palliative care early on. And not only identifying them, but as emergency physicians, we can start that conversation. I think that's the point I want to get across to all of you. It's also our job to start that conversation. Remember your ABCs, and like I said, have those different conversations, and practice makes perfect. So I want to leave you with a quote by the person whose oath we swore by. Hear sometimes, treat often, and comfort always. These are my references. Questions or comments?
End-stage cancer, end-stage dementia, CHF, COPD are two of the biggest killers out there. So remember that for those patients who live with progressive diseases. So these are conversations that we should have with those patients as well. I think we see very routinely about that. And then just to speak on medical futility, you do have the power as a physician to say something is medically futile. No one's ever been, if you feel in your medical opinion that the patient is medically futile to do this, you can go against what
Well, and I agree with that as well, that obviously that's what we do have power to do, but also, even if you're in that, I think in that uncomfortable period where you're trying to decide with going with the DNR versus actually going with the family's wishes in that instant, you could always intubate, and then this gives the family time. You can really still engage them, I think. Don't give up and just say, okay, we're just going to do everything and chest tubes and the whole nine, but I think still, you could still have that conversation with them continually. Because once they see.
The problem with that is, once you intubate, extubating is much more difficult and much more of a legal problem. So it's better not to intubate. It's actually the opposite. Because it takes a lot more legality and people in the hospital and the ethics committee to get someone off the ventilator. And so it's really important to have the discussion. So if you start off with the conversation and there's a DNR and DNI form and the family wants to go against that, this is when you really do have to take the time and ask them what are their concerns, right? It's mostly because they're scared. They've already talked to their family member, they've already had those discussions 5 years ago, but now the time has come. I would say that about 15% of the time, you could probably get them to understand what's going to happen with the TNR and DNR. But you have to sit and have those discussions, and it really should be, let's just intubate, and then we'll figure it out later. Because it's so hard to extubate them and to get them off the ventilator after that. You could have someone who's going to be on the ventilator for a year and go through lawyers and ethics committee just to get them off for the wishes that they wanted in the beginning to not be on.
So for the situation where you're going to have that you're not the doctor, you're actually the loved one, I would just make a recommendation that, don't try to act like the doctor when it is a parent or a dear friend. You take the role of the parent, or the child or the dear friend. You really have to have that distinction, number one. Number two, don't make the mistake that a lot of us have made and listen to what that dear loved one wants in the last, minute or two where there's a crisis. Respect what they said 6 months ago and 3 months ago and 2 months ago when they weren't in that situation and they were making a much better informed decision. When I first was an attending, I worked at Robert Wood Johnson. I did a lot of nights. I needed a lot of money for my, developing family and whatnot. I had a 28-year-old female with cystic fibrosis. I personally intubated her over a 6-month period about 4 or 5 times on night shifts that her family brought her in. The family was not ready to make the decision, so I intubated her, and she did not have a DNR. What I finally decided to do is when I heard that she was going to be discharged from the hospital, I went up there and I had a 2-hour conversation with her when she could talk and when she felt good and she was about to be discharged. And we came to the conclusion if she ever came back in my ER, and in that extremis, that I would not intubate her, even though she did not have, in those days, DNRs and things. And, as it be, she did come back in my ER, and I made her comfortable, and I let her go. So, I mean, you have to think about what that person would want to do when they're rational and they're in a comfortable position, how they really feel. Because a lot of times people are going to look up at you as this young woman did to me, and said, tube me, and I did. And that's probably not the best thing to do. So try to contact that person or try to be with, especially if it's a loved one, when they are in feeling comfortable, and then you could have that full discussion on them with them.
So I just want to say I really appreciate that you brought up the economics concept. Is that part of the things that they bring up with how they reach such a high rate of fabulous is that the medical community at every given point brought it up. Doesn't mean that I have to make a decision on your advanced directive at this point in my hearing, but I need to talk about it, and we're the ones that have to change the culture that we don't talk about it as much, and they show that it can be done.
I think there's also could be a misconception that DNR and DNI means not going to do anything, and it doesn't mean we're not doing anything. Just making that very, very clear to patients, because for understandable reasons, there's a lot of mistrust in the medical community.
That's a whole separate topic.
But we have to reassure them that.
Well, I think you're right. The problem is that sometimes that actually is true. That as soon as the doctor says DNR denied, they literally just turn off the switch and get on with their people. And it
So if they're not talking about it, we're not talking about it because the thought is that it might not be our job. The community is not going to know anything about it until they get to that point. And a lot of patients and a lot of patients that we encounter are at that last end where they're coming in and nobody knows what they want. So if we, like Dr. Willis said, if we have those COPD or CHF patients that are coming in and out of the hospital, we address it before, they might not be dying on this admission, and they might not be, they might have 1 or 2 years left. But if we just start discussing it every time they come into the ER, they're going to get used to it and they're going to start thinking about it. That was my goal of this discussion, this talk, to have all of us kind of engage our patients and put those thoughts in their head and have them talking about it. Because it's a very taboo topic within our community, within our the culture of the community.
I'm going to say this with take with a grain of salt, and it's probably only going to be for a very select case population, but terminal extubation is a thing. I had a case when I was a junior at CCT and Dan Sokola was my senior. I forgot the details of how the patient got intubated. The family came and they kind of saw how he was